All
Motion.
right, so I think we're getting close to it. So those of you who are here, let me introduce you Taylor Sanson, who's from Cidara, who's going to be telling us about their compound, resafungin.
Okay, thanks. So I've been asked to give a very, very brief presentation on where we are with the resafungin program. And just as a little bit of a background, resafungin is is an echinocandin, and it's been discussed periodically today. But it's just based on the inidulafungin compound. It's one chemical step from that, but has created a very stable echinocandin that doesn't break down to the same degree and can be dosed once weekly. We are currently with resafungin in two phase 3 studies. One, the treatment study Restore is just completed, and we had top line data in December, and we'll be presenting some of this data at ECCMID. And the other one is Respect, which is a prophylaxis phase 3, which is for the prevention of Aspergillus candida and pneumocystis in the allogeneic BMT population. That is an ongoing trial right now. If anybody's interested in being part of that, it's certainly we are still collecting sites and activating sites. So I'll just start with the treatment trial. As I said, we've been in development with this drug since 2015. There was a question earlier about whether the drug has negative inotropic effects, like inidulafungin. That was on one of the chat questions. And we've actually done a phase 1 study. In fact, the only echinocandin to do a phase 1 study in QT evaluation to found no changes in any intervals. We also had an echocardiogram part of that study that showed no negative inotropic effects, even up to 1,400 milligrams, which is 3.5 times what the week 1 dose is. So we've done this development program. We're currently just finishing up getting all the data for phase 3, and we've published some of the top line data. This was a randomized control, double-blind, double-dummy trial. We enrolled 199 subjects to get to 187 MITT subjects. For FDA and EMA were day 30 all-cause mortality, and then EMA global cure at day 14. And that was versus casbafungin with an optional step down to fluconazole. What we found was that the primary endpoints were met in terms of the all-cause mortality and the global cure, basically the same point estimates in each group for each outcome, with the numbers being well within that 20% non-inferiority margin for both outcomes, and actually within 15. The secondary endpoints were a little bit more interesting because the primary endpoints were basically the same, and even as you get out to day 15, day 30, were relatively equal between the two. But the early outcomes for both the phase 2 and the phase 3 were fairly consistent and favored resafungin to a certain degree, and goes along with our idea of a high front-loaded exposure, perhaps clearing infection a little bit faster. The exploratory endpoints, time to negative blood culture and duration of hospital and ICU stay, also did tend to favor resafungin to some extent, and may be related. We're kind of still looking through the data, trying to get into that, and we'll get some integrated data between the phase 2 and phase 3 as well. So that'll be interesting to see. And then for safety, this is basically an echinocandin. It looks like an echinocandin, and the adverse events and serious adverse events were similar between the two study arms. In terms of just getting a couple things that were a little bit different, I guess. So everything looked relatively similar, non-inferior to each other in terms of mortality and global response at day 15. But I did mention these early outcomes were kind of intriguing to us, and I've shown you here the Strive and Restore. So phase 2 and phase 3 outcomes here for time to negative blood cultures, or percent negative blood cultures at 24 and 48 hours, and for the phase 2 and phase 3 on the left. And then on the right, this is the basically the efficacy endpoints at day 5. So mycological cure and overall response, or global cure, excuse me, or overall cure at these two endpoints. So Again, as I mentioned before, this idea of this a once weekly drug, give a big dose up front. The idea is you can kind of get on top of the infection maybe a little more quickly. As I think Andre had said before, it's more of a kind of a brute force PK event. And that has shown us that even if it's these susceptible organisms, there may be an advantage in terms of clearing the infection a little more quickly, and whether that is related to the lower lower number of days in hospital stay and ICU stay, I think still needs to really be determined. But we see this kind of as the same story in terms of clearing cultures, mycologic eradication during the early time points. I mentioned before that our other phase 3 is in prophylaxis. This is prevention of invasive fungal diseases in the allogeneic blood and marrow transplant population. This gives you an idea of what the current standard of care is like: fluconazole, posaconazole, to try to prevent the majority of fungal infections. And then we also have anti-PCP medications, usually Bactrim, to do that. And risofungin does have really good activity against pneumocystis as well as Candida and Aspergillus. And just as a reminder, actually, echinocandins were initially developed to treat pneumocystis. They were known as pneumocandins originally. But the idea here is that instead of taking these azoles for some of these patients that often have toxicities or drug-drug interactions with a lot of the drugs that are being given in this population, that perhaps a once-weekly risofungin could suffice in giving you the same efficacy with fewer issues with toxicity and DDIs. So that study is, as I said, is ongoing. Comparator is the standard regimen of azoles and Bactrim through 90 days with fungal-free survival at day 90 being the primary outcome. And we are enrolling that currently. So with that, I will stop and see if we can have that catapult us into discussion.
So I'll get the ball rolling. So one of the things that gets talked about a lot with echinocandins and PCP is that there are different life stages of PCP, and some don't produce beta glucan as much, and therefore may actually possibly be escapes in echinocandin therapy. You want to comment on that?
Yeah, no, that's right. So clearly the cysts have a lot of beta glucan on it, and the trophozoites not to the same degree. So we've done a lot of non-clinical work with Melanie Cushion at the University of Cincinnati to look at both of these things. And what we found is clearly the risofungin works better than against the cyst form than it does the trophozoite form, but actually works for both. So certainly for prophylaxis, even at a fraction of the dose that we're giving, like 50, 60 milligrams instead of 400 or 200, it seems to be as effective as trimethoprim sulfa. When you get to treatment, it takes a little while, I think, it looks like, to treat these infections, to get on top of those trophozoites. In the non-clinical setting, it's more like 4, 6, 8 weeks, something like this. So I think that with the treatment, it definitely needs a little bit of help. For prophylaxis, it seems to be very, very effective. And while we look at, the echinocandins, relatively, like, they're basically the same when it comes to their activity against Candida and things like this. They're not all created equal when it comes to pneumocystis. And certainly, risofungin seems to be at the better end of that spectrum, followed by Nidula, Caspo, and then Mica.
All right, thank you for that. I'll invite anybody who has any questions to kind of write them in the chat. But another question that I have for you is that you have early data showing improved, or at least trending towards, I haven't seen any p-values, towards faster clearance or towards earlier mycological eradication. Does that seem to translate into a signal in mortality, or does mortality look pretty flat on the study?
Yeah, no, it looks relatively similar. It's hard to say there's much of a difference there. Certainly not as much as you would see with the early outcomes. There's a fairly comorbid population, and not many of these patients are actually dying of their candidemia or invasive candidiasis, they often, if they die, are dying of other issues, whether they're taking caspofungin or rezafungin. So we're not seeing much in terms of that clearance. And oftentimes, the longer you stay in the hospital, other things happen, or you follow these patients, there's more confounding issues that arise. But no, the short answer is no. Early outcomes, it's clear to see these differences, but by the time you get to kind of day 14 and day 30, whether it's global response or mortality, it looks relatively similar between the two.
Okay. Yeah, there's definitely a lot of confounding. But I would say that our group just published a paper in CID looking at attributable mortality in candemia, and we found that about half is still due to candemia itself. And that's disproportionately the case in situations where patients are less sick. So the really sick ones, it seems to be much more related to non-candemia, but those tend to be excluded from phase 3 trials. So suggesting that a lot of the mortality in the candemia trial should be attributable.
Yeah, potentially. Although some of the patients that are very sick also get excluded. So right. it depends. And our biggest thing is the biggest reason that that we would have screen failures during our study is because of prior therapy, right? And that's a bit of a marker for how concerned the doc is for how sick the patient really is, right? Do you need to give this empiric therapy? Do you suspect fungal infections and those types of things? In our phase 2, we found that patients who got no prior therapy actually did better than patients who got prior therapy. And we think it's probably what the bias was there that led to that, was this kind of, it's more of a surrogate of how worried the doc is, what the criticality of the patient is, that kind of stuff. So yeah, I think you're right in terms of the attributable mortality, and it will be interesting to see if there's any difference there.
Yeah, I think you're hitting the nail on the head when you said that that's a marker for the fact that patients are much sicker. We did the exact same thing with our data and analyzed retrospectively those who were started empirically and those who were not, and those who started empirically actually had worse outcomes, which clearly suggests that they were probably more sick, and so the doctors were more concerned about throwing more things at the wall and seeing what sticks.
Right.
So we haven't finished adjusting that yet, so we'll see how much that bears out to be the case. Right.
But just the antithesis of what you would have expected, right? Just given, actually from your institution, Marin Koloff, and the work he's done on, prior appropriate therapy being extremely important for having positive outcomes.
Yeah, I think the question is going to be really how important empiric therapy makes a difference as opposed to culture-driven therapy for candemia. I think that's really going to be the real question, especially given the new sepsis guidelines that kind of suggest that we give echinocandins very early. I really want to kind of open up questions for anybody else. I don't want to make this all about us.
It's like a fireside chat.
Yeah. One of the other things that's often seen with nidulafungin is flushing. Have you guys seen that with rezafungin, and how bad was it? Was it controllable?
I'm sorry, say that again. You cut out for me for a second.
Oh, I apologize. So for one of the side effects that we tend to see with nidulafungin is often flushing. And have you guys seen any flushing in the trials, and has it been manageable? Because you're giving a much higher dose than nidulafungin.
Yeah, no, that's right. So if you look at the nidulafungin label, you're not supposed to give it faster than 1.1 milligrams per minute, right? The rate of infusion. That's really what that echinocandin infusion reaction is about, is kind of the rate of infusion. And we have seen it more at the kind of the higher levels in our earlier studies. We saw it a couple times in our phase 2 and 3, but it's one of those things where if you see it, usually it goes away within a few seconds, or you kind of slow down the infusion rate and it goes away. So it has been seen, and certainly is related to the drug, but as you've noted, for the 400, we're given over 6 milligrams per minute, which is so a lot faster than initial fungin. But it's easily managed, and when we on the rare occurrences we have seen it, we just turn down the rate a little bit and it goes away.
Awesome.
Yeah.
Great. When do you think we should be seeing? This might be a difficult question to answer, and might be a question you may not want to answer. So in which case, I will allow you to plead the fifth. When do you think we will be seeing rezafungin on the market, given the fact that you guys have finished the phase 3?
Well, so I'll tell you what we were saying publicly, and then you guys can do the math if you like. But basically, we're expecting to submit for our NDA middle of the year, and then we have QIDP and fast track status with the FDA. So if things go well, usually that means that they should have a response to us within 8 months.
So on the lucky side, which this is me doing the math, you don't have to confirm nor deny, we might be seeing it by the end of the year or early 2023. So that's exciting to see more antifungals on the market.
Yeah, there's a lot out there, right? And they're all kind of seem to have their own niche on what what they're doing and treating. It's an exciting time because I think, as you noted in your presentation, there's a paucity of new things coming down the pipe for quite a while, and we've when I remember when I was a fellow and in faculty before I joined industry, even like 10 years ago, it's basically the same picture as it is now, and with relatively little difference. So I think it's going to be interesting, probably like 3 to 5 years from now, to see what everybody's doing and how everybody's being treated.
Yeah, I think so too. And then a question that gets often posed to other long-acting compounds it was asked of people, of isavuconazole or advancin, dobuvancin. Have you done any studies or any concerns for the long tail exposure giving rise to echinocandin resistance?
Yeah, so we've done some work with David Perlin and have not seen. In fact, the mutant prevention concentration it seems to come out better than it does with the other kind of candidates. But that's always going to be a concern, I think, when you have these long-acting drugs. That prolonged tail, does it develop into mutations like FKS mutations or the like? And we haven't seen that. We certainly didn't see it in the clinical trials at all. So, if we're fortunate enough to get on the market, I think that's certainly something we'll have to pay attention to is what happens with that.
Okay, so we have approximately 5 minutes left in this room. So if anybody has any questions, I would implore you.
I did get one question.
Oh, you did? Cool.
Basically, where the name rezafungin came from. And honestly, I don't know. I can't remember. I think it was probably what generally happens with these kinds of things is, there's a discussion about what sounds good, what people like. It's not supposed to mean anything. Generally there's like some sort of a consultant that comes in and tells you that this is maybe more for the brand name than the generic name. They'll say, things like, X's and V's are strong and things like this, where I don't know where that information comes from. But yeah, I for the person who asked that, I honestly don't know. I don't remember where it came from. It's just what it is now.
I think it is very true, at least, that of all the cell wall active agents that are coming down the pike, you guys do have the least painful name. As much as I'm interested, as much as I love all these compounds, it is a frequent moment of jibes to make fun of fosmanogepix and the ibrexafungerp.
Yeah, well, I think all of them are going to be abbreviated, right? Like we say Caspo or Mica, it's going to be Reza and Abrexa and
Manogepix or
yeah, I'm not sure about the other one.
Yeah, I'm guessing because it's manogepix is the actual active compound. I'm gonna go. It's probably gonna be mano. Okay. So we have a couple of more minutes left. If anybody has any questions, you can speak up, or you can send a chat to me or to Taylor. But if we don't have any, I figured the easiest thing would be to let us go back into the main room for a couple of minutes. People can take a little biological break if they need it.
Okay. All right. Thanks, Andre. Appreciate it. Good to see you.
All right. It was a pleasure seeing all everybody. Bye-bye.